Okay, it looks like we've started. So, good evening, everyone, and thank you so much for joining us tonight. My name is Jamie Adkins, and I'm the Vice President of Business Development at MedShift RX. And we are truly excited to have you all here and grateful for the time you've taken to be a part of this conversation tonight. We are especially thrilled to be partnered with Agari Sciences and to bring you this webinar alongside Dr. Luis Martinez. And we just think it's a great opportunity to collaborate with leaders who are helping push innovation and education forward in this space. So, tonight's topic is one we're particularly excited about: peptides that stimulate growth hormone. And that is, without a question, becoming one of the most frequently asked about categories that we're hearing from our customers. So, at the same time, we're consistently seeing a gap in clear practical education around these peptides and how they can be effectively applied within your practice to drive better outcomes. So that's exactly what tonight's webinar is about, and we hope you'll walk away with some incredible new insights. And for those of you who aren't as familiar with MedShift RX, we are the leading marketplace for more than 10,000 aesthetic medical practices. We currently work with over 50 leading manufacturers and partners, and we definitely think we've partnered with the best in the industry with Agari Sciences. So, with that said, I would love to hand it over to Heather Vermette, the president of Agari Sciences, to get us started.
Thank you so much, Jamie. And we appreciate all of you taking the time. I believe we've got over 200 physicians that have registered for this webinar, so we're very excited about that. And just to introduce our company a little bit, at Agari Sciences. So we are one of the leading manufacturers of peptides here in the United States. So recently, about 8 months ago, we started peptide synthesis in the US. So we're going to be one of the few doing this. So rather than just procuring the raw API from overseas, we're now synthesizing here. So everything end to end is going to be in the full ecosystem. And at our manufacturing facility, everything is CGMP with certified ISO 9001. So you're really getting the best of the best. And then anytime that you have questions regarding the certificate of analysis, material data sheets, how we do testing, just reach out to MedShift and they can assist you with that. We also do time studies on all of our batches, so to extend things beyond just a 90 days, where we can get 8 to 9 and 10 months validation on those. And then also, I'd like to introduce Luis Martinez, who's one of the co-founders of the Clinical Peptide Society. He's well known in the space, lectured all over, well known also at the MMG conferences. If you'll be at this next one coming up next month in April. So Dr. Martinez is well known in the regenerative side of the business. Also, he did his residency at the University of Pennsylvania and holds a master's in public health with a concentration in epidemiology. He is also board certified in lipidemiology. Am I saying that right, Dr. Martinez? I'm not
Yeah,
saying that right.
lipidology. Yeah,
Yeah,
that's fine.
exactly.
Yeah.
And with fellowship trained in biosecurity. So with that
Yeah.
said, he's going to take it over from here. And then at the end of this, if you'd like some additional training, there are weekend courses through the Clinical Peptide Society. So we can share a link to that as well as a coupon code because you are a partner with MedShift. So we'd like to assist you in getting some additional training too. Thank you.
Awesome. Appreciate that, Heather, and welcome and good night, good evening, everyone. Definitely we're going to start talking about, growth hormone releasing peptides, peptide secretagogues. It's a very popular topic nowadays in the peptide world, and there's multiple peptides that we can look at. So let's get things started here. This part already Heather mentioned about Agari Sciences. So let's look at a few things tonight. First of all, we'll do an overview of growth hormone secretagogue peptides. We'll look at mechanisms of action, receptors that are being affected, systemic effects of growth hormone stimulation, some of the clinical data and emerging insights. And as Heather mentioned, if you guys want some more training, we definitely have a lot of training courses. We'd love for you guys to come up. So an overview, first of all, of growth hormone secretagogues. So first of all, growth hormone physiology, right? It's secreted in the pituitary gland, and it's stimulated by GHRH, growth hormone releasing hormone, while somatostatin inhibits it. What are the main or major physiological effects of growth hormone, and how does this affect us in, longevity medicine, regenerative medicine, anti-aging, etc.? So a few things. One is growth hormone promotes lipolysis and enhances protein synthesis, and this is driven by IGF-1 production, which is one of the main components that we measure as part of the looking at response to some of these secretagogues. Usually, growth hormone is secreted in a pulsatile form, especially when we sleep, especially when we go into deep sleep. And production declines with age. So there's many things to look at, when we're looking at using these with our patients. Let's look at some of the secretagogue peptides. We have the growth hormone releasing analogs, GHRH. These target a particular receptor that stimulates growth hormone release. Some of them, probably the more known one is sermorelin, although it's not the most potent one. It has a short life, and I'll talk about each of the peptides shortly. In addition to the GHRH analogs, we also have the ghrelin receptor agonist, and these bind to the ghrelin receptor. And probably the more popular one right now is Ipamorelin. This one has high receptor selectivity for the ghrelin receptor. And then we have some hybrid peptide combinations. And I'm going to say the most common one currently used is the CJC 1295 with Ipamorelin. So we're targeting two receptors through this combination, and it produces very consistent results in patients. Clinical rationale for peptide therapies: a high percentage of patients report improved adherence and safety with peptide therapies. There's more regulations and more challenges with going straight into growth hormone therapy for patients versus using peptide secretagogues, which obviously work in a more physiological way. A way you can look at this, an analogy of sorts, is looking at testosterone versus enclomiphene, right? Stimulating versus directly replacing. So this is something like that with growth hormone. So let's look at some mechanisms of action and key peptides here in this space. Again, I mentioned sermorelin. It's probably the most known. And I would say kind of like an entry-level peptide for a lot of patients and a lot of practitioners in getting into the field. It is one of the growth hormone releasing hormone analogs, and what does it do? It's going to stimulate growth hormone. So this is going to help with restorative sleep, skin, muscle, fat redistribution. It's typically used in, patients that are looking at getting into the whole longevity, anti-aging, low IGF-1 levels. It's, again, milder than some of the other peptides. So it can help in a more gentle fashion, and because of this shorter half-life. And because it helps in a more gentle fashion, I think a very important thing here with sermorelin is that it usually needs a few months for patients to start seeing more consistent results. So that's something you need to take into consideration when using sermorelin. 10-minute half-life of sorts, administered sub-Q. It triggers a pulsatile growth hormone release throughout the night, and you start getting results slowly. Now, CJC 1295, it's a modified version. It's a longer-acting version of growth hormone releasing hormone. Now, it can come in two manners, and it can come with DAC, drug affinity complex modified, which will make for a very long half-life, days. We don't use it because it just, in that manner, because it just goes super physiological. So we use the CJC 1295 peptide. It still has a longer half-life than sermorelin. And in my experience, it promotes, it's a bit stronger, probably because of the half-life. Promotes slow wave sleep, muscle growth, definitely, and fat loss, fat oxidation. This one is in combination with Ipamorelin. It's sort of like a mid-level peptide here. You get faster results, and I guess a bit more consistent results than with sermorelin with that combination. So that's pretty good, especially, athletes, weekend warriors, or just people looking to have a more robust effect with this. And half-life, the modified CHC 1295 will have up to 7 days, but we use the non-modified one, which is a 30-minute half-life. We want it to be physiological, sub-Q, and again, it works in a pulsatile manner. Ipamorelin, this one targets a different receptor, so it goes for the ghrelin receptor. It's pretty selective. It's also gentle on its own. But again, we tend to combine it with CHC 1295 for more potent effects. Typically has been used more with women on its own, or also Sermorelin, less potential for side effects. It does not really, affect hunger or cortisol. So that's good. And it's also going to do the same, support mechanisms, muscle, lipolysis, deep sleep, improved skin. And this one is, again, very selective for the ghrelin receptor. And it has a bit of a longer half-life, 2 hours, but there's definitely a difference between the GHRH receptor and the ghrelin receptor in terms of response there. And then we have Tesamorelin. It's probably, I'd say, the most potent of this category. It's actually FDA approved. So Sermorelin and Tesamorelin are FDA approved. And it was approved in HIV lipodystrophy. It can help more potently with visceral fat loss and enhance muscle definition. I was actually seeing a patient today who started Tesamorelin about 3 weeks ago and cranked up the exercise, and he had pretty significant abdominal fat loss with this. He was very happy. It also has, as part of the studies, it also has effects on carotid intima media thickness decrease, and also potentially on cognitive function. So, again, it should be more of a class benefit, but specifically, we have some of the data there, studies with Tesamorelin. So you can look at, for example, I'll look at Tesamorelin for people that want to significantly increase muscle mass, decrease that central obesity, and I even use it with patients that have cardiovascular disease, CAD, and now they have some plaque and changes, vascular changes, because it has shown some benefits there. And I also use it in patients that are starting to have some mild cognitive impairment. So it's a very broad and potent peptide there. This was from one of the studies on percent reduction in visceral fat and HIV-associated lipodystrophy with daily sub-Q use. And also very interestingly with Tesamorelin, we have prolonged studies, and we have studies over a year of use, continuous use with the peptide. So systemic effects of these growth hormones, and again, I think we've gone over them, but just to summarize, enhanced lipolysis. And we're also seeing a lot of combinations with GLP-1s, patients losing weight, GLP-1s, and enhancing growth hormone release, IGF-1 signaling, so they can work well together. If growth hormone per se is overdone, it can have some side effects, as insulin resistance. You can have fluid accumulation, swelling, joint pain, and this is more on the excess growth hormone side. So this is minimized significantly with these peptides. So the side effect profile is much, much better. But yeah, IGF-1 mediation is going to support repair in all, on all levels. And when we talk about repair, we also use some of the other peptides. I think I mentioned some of them on the last webinar, but like BPC, GHK, TV4 or TV500. But I think that those types of peptides can also be combined with, growth hormone modulating peptides, such as these, to really ramp up repair in patients. It can help, again, if you're helping muscle, you can support bone density. it can address and help support lean muscle mass and improve some of the cardiovascular markers. Some of the side effects that we can see, there's local side effects like injection site reactions, which you can get with any injection. We even see those with GLP-1 injections, but yeah, like, some erythema or itching, rashes. With the growth hormone secretagogues, you can also get some like flushing. It can happen. It usually subsides in a few minutes. Now, if you were to go into excessive stimulation, then you could get into what I was talking about, like the insulin resistance, edema, arthralgias. So monitoring is very important, but these particular side effects are minimized dramatically with physiologic secretagogues versus direct growth hormone replacement. So clinical data and applications, just going over this again. Some of the actual FDA approvals, so Sermorelin was approved in pediatric growth hormone deficiency. Tesamorelin was approved for HIV lipodystrophy. And there's studies, again, CJC1, Ipamorelin are not FDA approved, but there's studies on the IGF-1 increases and related outcomes with these peptides. So indication criteria, obviously, you have studies which show specific populations that have been studied with these peptides. But nowadays, and on a positive note, you probably know about the limitations from an FDA perspective on growth hormone administration and the criteria to replace growth hormone. So that's not an issue with peptides. You can usually use these peptides with most patients that want to improve a lot of these parameters, as I mentioned, and you look at IGF-1 levels and target those. And you individualize the dosing for these patients. What patients should we not use these peptides with? Obviously, patients with active cancer. You're not going to stimulate growth hormone in this population. Patients that had like uncontrolled cardiometabolic conditions like diabetes, uncontrolled CHF and whatnot would not be good candidates. Or if there's any history of hypersensitivity, again, very rare, but you could have allergic reactions to any of these. But overall, it's very, very well tolerated and patients demonstrate good results. Dosing, there's multiple different dosings depending on the peptide, but usually we will give these peptides at night, a few like 30 minutes before bedtime, 30 minutes. Yeah. And we tend to recommend breaks, like weekend breaks, potentially or theoretically to try to minimize pituitary burnout. Monitoring, you look at changes in body composition, you look at changes in IGF-1 levels, and you look at cardiometabolic improvements, inflammation, glucose. So again, for most patients, these growth hormone secretagogues will be an option. And depending on, patients and protocol, periodically we like to take breaks.
Dr.
Give them a
Martinez?
break. Yes,
Oh, can you go into just a little bit more? I know some questions maybe coming up regarding, do you like the 5 days on, 2 days off,
I
or do
like
you like
that.
to see patients on for many months, or does that vary based upon if it's going to be
Yeah.
CJC, Tesamorelin?
Yeah, that's a really good question. I tend to like the 5 and 2. I tend to like the 5 days on, 2 days off. That can change depending on a few things. Like, for example, sometimes if I see that patients are having a slower response to the peptides, I might try to max that out and go continuous for a few weeks or even like a 6-1 schedule. Because you definitely, especially with the more, with the less potent peptide like sermorelin. So that might change depending on patient response. We do know from personal experience and from studies that you can technically go on continuously with these peptides. Like, tesamorelin was used for over a year in one of the clinical studies. So you can technically go. I think the break that we offer is not only beneficial for potential gland burnout, but also like patients kind of like to take a break from injecting every night. So it's also like a practical thing. And that always helps.
And do you ever change it up? So have a patient, let's say, start on Tesamorelin and then move them over to CJC?
Yeah, I have done that. I have done that. And it, you know, most of the time, to be honest, it depends on patient response. Most of the time, if you have to move a patient, it's either because the peptide they were on was not potent enough for them. Like, you switch them from Sermorelin to CJC-IPA, works better, they like it more. So that's usually an indication. I have had actually on occasions had some patients where it's been the contrary, where the like for example the tesamorelin worked really really well, but they got a bit too big, and even they just wanted something milder. So you can always go to a less potent secretagogue. Again, it goes back to patient selection. Do you have any other questions related to this?
We don't have any more that came in
Yeah,
just
yeah,
yet. And then,
that's pretty.
do you
Yeah,
ever vary based upon, sometimes starting with one thing, if it's a younger patient versus an older patient? So if somebody coming in maybe in their 32 and they want to start off with some of these versus somebody who's
yeah.
65?
Yeah, that's a really good question. Yes, and it again really depends. Usually, you know, it's one of those things where younger patients or even like female patients might do better on Sermorelin, Ipamorelin. Um, Male patients or older patients that need a bit more of a stimulus might have to go with the dual blends or the Tesamorelin. We have the data for the Tesamorelin in varied age groups, and so yeah, I would say again, it's not specific, but kind of like a overall rule of thumb. We, younger patients, female patients, tesamorelin, ipamorelin, male patients, more athletic patients, and older patients, CJC, IPA combinations, and tesamorelin.
Great, that makes sense. Okay, now we're
Yeah,
getting some more questions coming in.
there we go.
And these two are sort of related. So this is regarding checking the IGF-1. Do you check the IGF-1 in the
I,
beginning? And then how
yeah,
frequently do you check that or with anything in addition?
yeah, I definitely do check IGF-1 in the beginning, establish baseline for the patient, and then usually I will follow up with IGF-1 levels 6 to 8 weeks after it. And it really depends because, for example, with the tesamorelin, there's studies and there's data showing rapid IGF-1 response. So you could potentially follow up IGF-1 levels in a patient with tesamorelin at 3 weeks, and you should see changes. Now, having said that, ideally, we want most patients should be on on treatment for at least 2 to 3 months. So you're not gonna have to test all the time. So usually I'll test midway through about 6 weeks, see how they're responding, see how the IGF-1 levels correlate with their overall subjective and um, body composition changes, and decide from there.
Excellent. And then once you've tested, so if you've tested a few months out and you're seeing the numbers that you really
Yeah,
like, and a patient needs to take a break, whether that's, financially to take a break
yep,
or they're
yeah.
traveling abroad or something, how long do you anticipate before their IGF-1 starts to fall down again?
I mean, IGF-1 could fall down relatively fast. Again, on the tesamorelin studies, even like post 3 weeks after stopping tesamorelin, the IGF-1 levels dropped significantly. But that's fine. I mean, I think that, and again, this goes really back to the longevity argument. There's a lot of studies in longevity medicine on lowering IGF-1 levels and prolonged lifespan in some of animal models, and they've looked at certain populations that have lower IGF-1 levels, but because of the cancer rates and all the other stuff. But what we know, and what I believe makes a lot of sense, is cycling where you can go up with IGF-1 levels for a few months, reap the benefits, get the muscle mass, which is very protective for the patient, drop the fat, get them to sleep more. And then you take these breaks where IGF-1 will go down a bit. You can stimulate during the breaks, you can stimulate, you know, autophagy. You can stimulate senescent cell clearance. You can use a senolytic. You can do multiple strategies to sort of try to clean out the patient, the organism, and then you can reset and go back again on the secretagogues and ramp up again. It's really type of a cyclical nature, and it works really well that way.
Fantastic. I like that.
Yeah,
Some other questions coming in. Is there a starting dose? So the question is related to concentration, and the
yeah,
concentration really will depend upon the milligrams per vial and how they choose to dilute that. That was a question that
sure.
came in. But for you, Dr. Martinez, is there a starting dose for some of these that you like to begin with for patients?
I'm gonna say come visit us at our conferences. Nah, just kidding. Well, you come visit us, but yeah, I mean, a lot of the times we start in micrograms, and it can be somewhere between 100 and 300 micrograms, depending on the peptide. So that's like except tesamorelin, which you go into like the milligram doses. But for the other peptides, it's micrograms, 1 to 300, and you adjust from there.
Right. And then, I'll say on the side of from Aguirre Sciences, the
Sure.
preparations that we have, the vial sizes are truly set to be a 1 month supply in most cases. If you as a physician or provider are doing a standardized dosing, we will be coming out with some higher milligrams on the tesamorelin soon, and also IGF-1 will be coming out soon as well. And
Yeah,
another
that
question for
definitely.
you.
Oh, I'm sorry. Go ahead.
Yeah, another question for you, Dr. Martinez. Let's see. What is the range for IGF-1 levels that you like to see?
That's a good question, and it's highly debatable within the field. I mean, I like to what when on treatment. Like obviously, like I said, it's going to go down when we take a break. But when on treatment, I like to have IGF-1 levels around 250. That's a good spot there, and then they'll go down when we break, which is fine, and then we'll go up again.
Okay. And then another question we have here is, let's see, room. So related to room temperature. So we do recommend that everything stays refrigerated. If something is out for a short duration, that is fine. But extended heat, extend a lot of heat for an extended length of time is a no-go. It is probably going to break down that peptide.
Yeah,
See, and then
keep
would you
yeah.
recommend using what kind of increases IGF-1 in addition to some of these peptides? Is there anything that they can do hormone related?
Well, I mean, so a few things. You always want to optimize hormones. So definitely. I mean, if you're using peptide secretagogues and your patient has low testosterone, right, and you don't correct that for that, you're gonna have a suboptimal response. I think they go hand in hand. So that's one thing. And then the other thing is, there's like certain amino acids that can be used to also help stimulate um, growth hormone release, and one of them is arginine. You can go into high doses of arginine, and there's multiple amino acid combinations that can also help with that. So yeah, you want to integrate, optimize hormones, nutraceuticals, and peptides.
Amazing. Okay. Another question here. Have you seen any major differences in the clinical results related to CJC with DAC or without? So DAC for everyone being that drug affinity complex.
Yeah,
And do you have a preference to one way or another?
I prefer the non-DAC. I just feel that the DAC is just not physiological. It's just not the way that we have, growth hormone is released. So I prefer a physiological pulsatile release, which is lost when you do that because of its prolonged half-life.
Sense. And we also do not offer the one with the drug affinity
Yeah,
complex
no,
exactly for that reason. And
correct.
so another question related to the A1C levels and insulin, is that something that should be checked prior to using a drug like a tesamorelin?
I mean, you know, ideally, yes, you want to have all the information on your patient, and obviously, we want to bring A1C to as low as possible, right? So it's always a good thing to have. And I have seen improvements in A1C when they're doing peptides such as tesamorelin, and body composition improves. Is it strictly necessary to start someone on tesamorelin? Probably not, but it's definitely a good bit of information there.
Nice. Okay. Well, we cleared through a bunch of the questions, so I'll let you continue with your slides.
Yeah, I
Thank
mean,
you.
I think that was really the end. I mean, the only thing I was going to mention is probably on the emerging, side is we're looking at there's studies now looking at how these peptides could impact like neurodegeneration, and I mentioned using some of these peptides in mild cognitive impairment, and so there's definitely research on that, and there's obviously the integration with obesity and GLP-1s, and also addressing frailty and aging. So that's that. And then there's, novel formulations that are being looked at, improving bioavailability, potency. So there's always room for improvement, as I say, but I think we're doing quite well. And then just to finish off, again, I think it's very, very important. If you're going to go into this, clinical education is a must. Get trained, get certified. We offer training programs and certification, protocols, and just, collaborate. That's part of what we do. We have the Clinical Peptide Society very active on this. So it's there. I know Heather's going to share the information with you guys. And we have multiple training programs coming up. We go into cases, specific protocols, more data, more evidence. So I think it's very useful. The peptide, let me tell you guys something. The peptide field is growing hugely. So you want to stay up to date with everything. And also, just also a thought here. I think it's very important. Responsible clinical practice requires transparency, informed consent, and adherence to evolving regulations to ensure that there's equitable access to peptide therapy. So these are the conclusions. I think we went over some really good questions there. I think it was pretty good. I don't know if there's any other questions left, but that's it.
We are starting to chirp with lots more questions coming in, so we do have a little bit longer. So I'll just go through these. So, would you ever treat a patient who's under 18? And if so, is there particular consent?
I mean, so I don't do pediatric patients, but if you were to treat a patient under 18, I think probably Sermorelin would be the best bet because of the data on pediatrics. So that would be a really safe peptide to use in this population. I mean, there's definitely a consent that we have for peptide use in patients. It could be modified for pediatrics, right? Again, depending on whether you guys want to treat pediatric patients or not.
Nice. And then anything related to injection site reaction or bumps that is common that you
Yeah.
see?
Yeah. I mean, sometimes, especially in the first few days of injection, some patients might develop like injection site reactions, redness, erythema, maybe a little itching. I've also noticed it's really interesting. I had actually a case today. I also noticed that sometimes patients don't inject properly, and that can also predispose to certain reactions. And I'll give you a specific example. So I had a patient today. He was injecting too superficially, was going really intradermal with this rather than sub-Q. He was having a lot of redness and itching and whatnot. And then he himself, like his wife, noticed him injecting, and she told him like you have to go deeper. And he was so scared of the needle, and then he actually went into the sub-Q space, and the reaction stopped. But you can always tell patients, these reactions can happen, and you can always take antihistamines or even topical steroids or to reduce reactions if they occur, and just always let patients know they should reach out if anything worse happens.
Then, with that said, this was not a question that was asked, but I think you're bringing up some great points there. Is there some sites that you really like for injection? So maybe the belly, but anywhere particularly on the belly. And then for sub-Q, what
Yeah.
length of needle do you like?
I always say aim for the fat. So grab that piece of fat wherever you can find it if you have some and go deep into the fat. Usually, an insulin needle, short needles should be enough. I mean, just make sure you can go through completely. And it'll be okay. I mean, it's you're not going to pierce your abdominal cavity with that needle. some patients get a little scared. At the office, we'll go over this with patients, how to inject and what to do. And that always helps.
Nice. And another question, we've got a couple of questions that are similar. So, do you like separating out a growth hormone releasing hormone and a growth hormone releasing peptide, or doing them together in one vial at the same injection?
So together works really well. Again, I mean, you can do both. There's no right or wrong answer here because the concern would be issues with mixing, but we know we can mix like CJC and Ipamorelin without a problem. Great results, well tolerated. So that's not an issue. Some patients or some doctors prefer separate injections for these peptides. And I know there's been a lot of noise on social media on peptide mixes and whatnot, but we can definitely mix them without a problem. My thought process is anything that makes it easier for the patient while still working, that's what I'm going to do.
Perfect. Let's see here. We also have, and then would you recommend doing twice a day dosing for some patients versus just in the evening?
I mean, that's another interesting question. You could potentially in slow responders, but when you do that, you're sidestepping normal pulsatile response, right? So if you do that, you need to keep that in mind. It should not be something that you would do continuously. Again, you could perhaps consider that if a patient is a very slow responder, but I tend to really favor just nighttime injection once a day.
Fantastic. Okay, we've got just a few more minutes for the last questions. We've got here, what about using simultaneously Tesamorelin and, oh, so what about using simultaneously SPA? Sure if they mean Simorelin or semaglutide, but what about using two growth hormone releasing hormones together?
Um, you could. I mean, usually not necessary. They're both targeting, I mean, unless you're combining a ghrelin receptor with a GHRH receptor. If not, then you're just targeting the same receptor with two different peptides. Potentially a difference because of mechanism like half-life and whatnot, but it's usually overkill. I would say it's overkill. I would say if you're having any issues with one of the peptides not working strongly enough, like for example, sermorelin, then just go to the next peptide that can work stronger, like the CJC or the tesamorelin.
Fantastic. Okay, well, that's a wrap for this evening. I'm going to turn it over to Jamie. I know that we will have some new products releasing into your inventory and stock very shortly. We're expecting some of those to come out next week, and we value our partnership so much with MedShift. And as I know that you do, we look forward to great things ahead.
Likewise, Heather. No, I really appreciate it. And one final question that came in over here, uh, Dr. Martinez. I know you have
Yes.
some great resources on the Clinical Peptide Society.
Yep.
Obviously, all the education you provide, but we had someone who was asking about the data that you had referenced in some clinical studies. Where would providers or clinics find access or gain access to something like that?
There's obviously the data that we have there's multiple published studies on some of these peptides, like the sermorelin and the tesamorelin. They have they're FDA approved, so there's plenty of published studies on them. There's also studies on the CAC and others that have been published in, like Australia and other countries. Practitioners can always look at sites like PubMed and do some of the research on that and get the data. But again, also we could, they come to our training events, we can definitely share a lot of the published information with them.
Oh, fantastic. Well,
Of course.
thank you. And Heather, I saw you put some links there as well, which everybody should definitely take a look and access those links. I just want to say thank you so much, Dr. Martinez. This was
My
great. And
pleasure.
Heather, as always, we truly appreciate our partnership and really enjoy working with you all. Thank you to everyone who joined us this evening, and we look forward to having you on the next event.
Have a good night.
Good
Thank
night.
you so
Thank you.
much.
Bye.